Hello, 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 my friends. Whoops, oops, I lost my butterfly. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, May 28th, and it is time for another IC support group meeting. But this is a difficult one. So I have a lot of news to share. I have a lot of news to share from the American Urology Association meeting, a whole new discussion of the microbiome that in the IC patient, which is, I think, going to give us pretty significant clues about some of the potential infectious organisms that could be involved in IC. I've got a really nice new treatment protocol that I'm going to share. And of course, I'm absolutely going to take your questions. And for those of you who don't know me, I'm the National IC Support Group Leader. I've been a support group leader for over 30 years. And that's my job. I run the IC Network, which is one of the largest archives of IC information in the world, which you can find here. If I put this over, let me move this over a little bit. At icnetwork.org. Can we all see that? Almost. Wait, almost. Let's try that again. So, there we go. Now we can see it. But I have to start with really hard news. Many of you have met my wonderful parents in these meetings, my mother and my father coming in over the years. And you know that I have provided their care for about 15 years now. This is their picture. Well, we lost them. My dad, Jack, had a heart attack that was not survivable. And my mom just couldn't live without him. So we lost my dad on the 12th, and we lost my mom on the 17th, 5 days later. And you know, I always thought that I was prepared. And I often imagined, okay, Jill, if you lost mom, would you and dad be okay? And the answer was yeah, definitely. And if we lost dad, would my mom and I be okay? And the answer is yeah, definitely. Could never have fathomed or imagined that I would lose both of them in days. And it has been agony. I'm not crying as much, but I think you know that my daily life has been intertwined with theirs for so long. And so now my house is quite empty. I feel my dad all the time. The irony too is as we spent hours and hours and hours at the hospital, we all got COVID. So I got COVID for the first time, and I'm still kind of don't quite feel. I mean, I'm walking. I've got not as much energy as I did before, but like little bits of congestion are definitely still there. So anyway, it's hard, and I want to thank everybody who sent me notes. For those of you, we're simulcasting right now on YouTube and Facebook. So this is new for people on YouTube. On Facebook, I have been sharing what was going on for the last couple of weeks. It just gives me purpose, you know, because the IC network would not be here today if they had not cared for me. The IC network would not be here today if my mother hadn't driven me to San Francisco to help me get care for IC and to reduce my pain. I would not be here today if my dad hadn't taken me to the emergency room several times. And I owe the success of the IC network to my parents and their support. And so what we're going to do is we're going to honor them. Absolutely. Absolutely. Laura says, I don't know what your beliefs are, but I like to think we will see our loved ones again. Absolutely. Definitely. Definitely. I have no doubt about that. Jessica, thank you so, hun. Thank you so much on YouTube. And Michelle, thank you too, hun. You guys, it's, oh. So we're doing a lot of cleaning. Anyway, I have to show you the one thing that my mother saved that made no sense to me, and I was just shocked to find it. Actually, my sister found it. You know what this is? This was the hospital band. You see the Dr. Andrew Thusen, A. Thusen. This was the hospital band that I had in 7th grade for my very first IC bladder examination. So I was 14. I am now 62. She saved this for 45 years in her dresser. How funny is that? Oh, mother. Absolutely hysterical. Absolutely hysterical. So, and I love this doctor. I had urethral dilations back then, which we don't do now. But he did them kind of like a rescue installation. And so because I had a very narrow urethra, and of course back then they didn't know about pelvic floor dysfunction. The cause of a narrow urethra is you normally tight muscles, but we didn't know that back then. So back then what they did is they inserted a metal rod, a urethral sound, small ones and then larger and larger, the goal of which is to stretch the urethra. Not the funnest thing in the world to do, let me tell you. No, not good at all. But he had a way. He did the urethral dilation, but then he did a rescue install. And man, this was back in the 70s before we knew about rescue installations. So thank you, Dr. Andrew Thusen, for not hurting me further. Now, so a lot of big IC things have been happening in the last couple of months. So we had a fantastic class on IC done through the International Pelvic Pain Society. And I have to watch it again. It was, I mean, they're the ones who are absolutely leading the way. Okay. They're the ones who are helping us understand, you know, intrinsically why patients develop the variations of IC. They're the ones who have helped us understand phenotyping, that we have distinct patient groups. And I have to tell you that the doctor who taught this class was brilliant. And there was a quote in there. I'm waiting for them to post a video because I want to get the quote just right. But so remember our fundamental construct here. We're not all the same, not even close. For some people, IC begins in childhood. For others, it begins after menopause. Are they anatomically the same? No, we're not. For some people, IC begins after chemotherapy, while for others, IC begins after having a baby and falling on their tailbone. Are they the same? Absolutely not. We now very clearly understand that there are distinct patient groups. We are long past the days of saying, hey, we think you have this incurable bladder disease called interstitial cystitis. Here's a diet. Here's some Elmeron. I'll see you in 6 months. We know bladder therapies don't help the vast majority of patients out there. We know that. Why? Because of this diversity. You can't put apples, oranges, and bananas in the same study or give them the same treatments and expect them to all be the same. We have diversity. So we have been using a system for years. I've been using the Chris Payne system, which focuses on 5 core subtypes: Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, and widespread pain central sensitization. And this has been fantastic because now we can find the right treatment for your unique case of IC. Okay? So for that patient with tight pelvic floor muscles, bladder wall therapies are not going to be that helpful. For the patient with Hunner's lesions, Elmeron is going to do nothing. We need to do, or probably not going to do much. We need to do Hunner's lesion specific therapies. For that patient with widespread pain, our focus has to be on calming the central nervous system down, right? Okay. So anyway, getting back to this class at the International Pelvic Pain Society, he explained it, I thought, perfectly about why do patients end up with this progression of symptoms. Some of us. Why does it start with, let's say, a tailbone injury that then spreads throughout the pelvis, and then before you know it, you have bowel symptoms and you have bladder symptoms, and then before you know it, you've got massive anxiety disorder and central sensitization and all that other stuff. And what our research is showing us is that 85 to 90% of IC patients have tight pelvic floor muscles. And I know it's freaking confusing. You've got frequency, urgency, pressure, pain. And you're going, come on, it feels like a UTI. It has to be my bladder. It has to be my bladder. Well, guess what? Tight pelvic floor muscles cause frequency, urgency, pressure, pain. In fact, tight pelvic floor muscles are more notorious for causing frequency, urgency than bladder wall symptoms like Hunner's lesion. And that was a new research study that was presented at AUA a couple weeks ago. And it's often mind-blowing because you walk into the doctor and you go, come on, it's got to be a UTI. It's got to be a bladder infection. It has to be. Well, for many, if not most of us, it's really not. That the muscles are playing a huge role in our symptoms. And again, during this class, he talked about how our symptoms often begin with an injury or a trauma that begins this whole process of muscles becoming tight and nerves becoming inflamed, leading to all of these symptoms of IC, IBS, vulvodynia for those of us with widespread pain. So just fantastic class. I want to watch the whole thing all over again before I talk about it a little bit more. Then, of course, we have the annual American Urology Association meeting, which ended a couple weeks ago, ended on May 1st. And that's where all the top IC research is presented. Always very exciting. And if you watch my last video, which is on YouTube or Facebook, I went through the 12 new IC studies in depth. But they also always have a class on IC. And I'm going through the class right now. And it's so much better than it was 10 years ago. We've learned so much. I mean, it's just so exciting. We have learned so much. But there was this whole new section on the urinary biome that I'm going to go over with you. Because I think this is a big, giant piece of the puzzle. But before we get to there. So the class was taught by Dr. Henry Lai, and then Dr. Ackerman from UCLA and Quentin Clemens, who's been a MAP Research Network researcher for years. So they're really a lot of the top IC doctors, that we worked with years ago have retired. So these are kind of our new leaders in the community. In Dr. Lai's section, he was talking about the updated AUA guidelines. The AUA acknowledges that there are distinct patient groups, and he had one slide that was the slide that he wanted every doctor to remember. And I want to show this to you. I want to show this to you because this really helps us understand the context of treatments. And I know for those of you on YouTube, this is backwards. I will have this on our website also. Here, hold on. Let me, let's see. There we go. It's so hard because I can't see it. There we go. Okay, so in the typical IC patient, if that patient has Hunner's lesions, we're going to treat them with lesion therapies, fulguration and triamcinolone. That's a treatment priority for somebody with Hunner's lesions. If this patient presents with high tone pelvic floor muscles, we're going to do pelvic floor physical therapy. If this patient has widespread pain, the IC, the IBS, the vulvodynia, this is when we're going to use more of the medications. The tricyclic antidepressants, the gabapentins to calm nerves down, the cognitive behavioral therapy, which can really help calm the central nervous system down. Really a multidisciplinary approach to treatment. And we're really focusing on body-wide treatment, systemic treatment. We're not just going to calm the nerves in the bladder down. We have to calm the entire central nervous system down. And then getting back to this bladder-centric group, we've got the Hunner's lesions, but we also had patients, there's a group of patients who do respond well when you put an analgesic like lidocaine in their bladder. If you respond well to a rescue installation with lidocaine, then we might use more intravesical therapy for this group of patients, right? So this really represents where we are right now. Pelvic floor patients need physical therapy. Hunner's lesion patients need fulguration or steroid injection. Patients with kind of bladder wall centric symptoms might do well with bladder installations. And patients with widespread pain, we're focusing on calming the central nervous system down, perhaps with tricyclic antidepressants, gabapentinoids, chronic cognitive behavioral therapy, and other things like that. Okay, so again, if you're not responding to therapy, if you're getting worse rather than better, what our guidelines say is stop what you're doing, take a step back, and revisit the diagnosis. What's different? Have we missed something? And some of you stop physical therapy way too soon. You're like, you do it for a month, it's not working, and you walk away from it. You have to understand that there's a terrible toll of tight pelvic floor muscles. And that terrible toll is ischemia. If you have tight pelvic floor muscles, it's going to restrict blood supply to the bladder and other organs. We've got to get the blood flowing because a good supply of oxygen and nutrition helps the bladder wall heal and repair itself. Okay. And then, I think it's very important to be the squeaky wheel. If you have pain in one spot, if you have pain on the left side, pain on the right side, that's not your bladder. There's something else there. You got to ask your doctor, what's at that location? Is it a trigger point? Is it a Hunner's lesion? We have to figure that out. So you are truly an anatomical mystery to be solved. Thank you, Kayleen. Here, hold on a sec. Let me go back here. Thank you, Angie. Hi, William. Thank you. Thank you, Angie. Thank you so much. I really appreciate that. Laura says, or here, hold on a sec. Annie says, for the patient with a pelvic problem, the food is not supposed to be the trigger. Well, like I just said, there's a devastating toll to long-term pelvic floor tension, and that is a decrease in blood supply. So if your bladder is supposed to get 24 units of blood a day and it's only getting 10, are you going to have a healthy bladder wall? No, you're not. So is the pelvic floor patient diet sensitive? Yes, you are. You will be diet sensitive until we restore blood supply and give all of these tissues a chance to heal. So like now, I have no dietary limitations with my bladder, none. I can eat oranges. I eat mandarin oranges a couple of times a day. I can drink soda, although I shouldn't be doing it. Here, hold on a sec. That was my doorbell. Hold on. Oh, thank you, Alfredo. Oh, thank you so much. I really appreciate that. Oh, they're gorgeous. I'm doing a live stream right now. So I'm going to go show you some live stream. Thank you. I've got about 25 patients I'm talking to right now. Thank you. Oh, that was my neighbor. Everybody now is learning that my parents have passed, and this was my neighbor who brought me some peonies. Isn't that pretty? We'll put those right there. Oh, it's nice to know that people, you feel so alone, right? And it's nice to know that there are people out there who understand that, on the inside you're crying and you need a lot of support and a lot of hugs, and I'm getting that from my neighbors. Whew. Okay. So let's go back here. So again, the pelvic floor patient is going to be diet sensitive for a time, but as you address your muscles and restore blood supply, and that bladder is given a good oxygen and good nutrition, that bladder wall should repair itself, and you may not be diet sensitive as time goes on. Laura says, I'm fed up with being told different things from different doctors. My conclusion is that there are many factors which have caused mine. Absolutely. You are an anatomical mystery to be solved. But for many of us, it's all driven by an early trauma to muscle, an early trauma to bone. Or even I was working with a patient on Friday who new IC symptoms, fairly new bladder symptoms, but what she thought was a long history of UTIs, which most of you think you're having UTIs when you're not. But when you go back in time, it's like, okay, can you remember any trauma? Yeah, really bad tailbone injury. Tailbone injuries are classic injuries that we see in the IC patient population, along with birth injuries and things like that. Elena says, have you ever heard of an itchy bladder or urethra? No pain. Definitely pelvic floor dysfunction over here. Bladder urgency started from a UTI 15 years ago in my teens. The itchiness comes and goes. It's the only sensation I can think to describe it. Definitely not inside the vagina or the vulva. It's in the lower abdomen. And, Elena, that really sounds like you have a nerve that's talking to you. Nerves. When nerves are provoked, especially by tight pelvic floor muscles, you get pins and needles. You feel like you're getting poked. You feel like you might feel areas of numbness, or you might feel areas of hyper irritation too. It's an interesting symptom. Another confusing symptom for me is the symptom of pressure, where you feel very, very full. You feel very, very full, even if you're empty. And some people describe pressure, like I don't think I've ever had the sensation of pressure, but I've definitely had agonizing pain. Whereas for many of you describe your symptoms more as pressure than as pain. I think that's just a different way that our brain interprets pain, for lack of a better term. Okay, so what I want to do now is I want to go into listen, the class that was taught on IC was stunning again. And for the first time, they had Dr. Ackerman, I think from UCLA, either UCLA or USC, who went on this in-depth discussion of the role of bacteria. Because you have to remember, we have a lot of people online who says everybody with interstitial cystitis has a what we call a fastidious infection, or an infection that's very difficult to culture, right? That's been a thorn in our side, for lack of a better term, for decades. I mean, back in the old IC Internet News Group, that was a constant thought that, there were people saying every IC patient should be on antibiotics. And of course, for those of us back then who did long-term antibiotics, it was significantly bad for us. That the use of antibiotics over time does take a toll on our urinary biome. So what is our urinary biome? Well, urine is not sterile. It is simply not sterile. Urine has a population. In fact, they say for every cell in the human body, there is a bacteria in the human body. That there are millions and millions and millions of good bacteria in our body that play really critical roles in how our body functions. And as an example, there is a specific species of bacteria that produce food for the cells in the human body, like the cells in the gut and probably also the cells in the bladder. And so if you take an antibiotic and you kill the good bacteria, really bad things happen. We call this dysbiosis. We end up disrupting the normal mechanism in which our body stays healthy. Bacteria are not our foes. Bacteria, the vast majority of bacteria, are our friends. They're critical to us, to our survival. So, the big question is quote unquote IC, quote unquote, the result of a chronic infection that they have not been able to detect with a typical urine culture? Well, Dr. Ackerman was mind-blowing. So number one, she summarized the data to date. And what the data to date generally shows is that the biome in the IC patient is almost identical to the biome in the normal patient. They were looking for Helicobacter pylori. If you know what Helicobacter pylori is, that's a bacteria that causes stomach ulcers. And the doctor who discovered the Helicobacter pylori was laughed at. He would think he was from Australia by his colleagues for years. There's no way the bacteria can live in the acid of the stomach. Well, he proved it. And now we know the vast majority of ulcers in the stomach are caused by this unusual bacteria that can live in high acid environments called Helicobacter pylori. And so you can darn well bet that the IEC research community has been looking for the smoking gun, something like Helicobacter pylori in the bladder. And they simply have not found it yet. What most of the research studies to date have found, and I want to say that we do this with next generation DNA urine testing. We're not just doing urine testing based upon trying to grow a bacteria out. Now we have new techniques to identify bacteria that look for DNA and things like that will help us understand what's actually in your urine, right? So her question was, can we use the urinary microbiome to diagnose and categorize bladder pain? Will it teach us about the disease pathophysiology, and will it help us predict response to treatment? The vast majority of research performed today shows that the IC biome is normal when compared to people without IC. The only thing that they found early on was that we didn't have as a diverse population of bacteria. We had fewer species of bacteria than the normal population. So our urine was less diverse, and we had more lactobacillus. So when you take a probiotic, it's usually lactobacillus. So we're going to come back to that because that's a very, very important point. Now, the other thing that we have to understand, remember, we're talking about, can you put apples and oranges and bananas in the same study and expect the same result? Well, the same is true with the urinary biome, because the urinary biome changes as we age. So there are patients under the age of 45 who have a very distinct biome versus patients over the age of 45 who have more things going on. And we know that because as estrogen levels change, acid levels change, the flora becomes more receptive to bacteria, et cetera, et cetera. So, let's see, how do I want to say this? Okay. So what she did is she expanded upon the early research and made it much bigger with more samples. And again, she found the same thing, that there was no significant difference, except there was a bunch of lactobacillus, a little bit of corynebacteria, more found in men with IC than women. But the big thing was the lactobacillus. So her question then became, let's see if I can get here. So her next line of thought was, okay, let's split these two groups apart. Under 45, over 45. And what she found in the patients under 45 was a really massive population of lactobacillus, whereas the patients over the age of 45 to 60, you had a lot more E. coli, you had Aerococcus, you had Gardnerella, etc., and that those are a normal part of the biome. You know how we always chase E. coli? Well, some of her information shows that patients who don't have any bladder symptoms and they're over the age of 45, will often have a population of E. coli, and they're asymptomatic. And what does that tell us? That suggests, okay, that E. coli kind of belongs there, right? In a limited population. Okay, so hold on a sec. So here's the difference she made. She started looking at species of lactobacillus. So you've got the classic lactobacillus that you find in a probiotic, the good bacteria, right? And for people who had no bladder symptoms, they had a good species of lactobacillus. But patients with bladder pain had a different type of lactobacillus called Lactobacillus iners. And what her research shows is that patients with pelvic floor-driven pain had normal biomes, but patients who struggled with bladder pain had a lot more of this unusual Lactobacillus iners. Now, so how did she say this? So the patients with non-urologic pelvic pain, so the patients with widespread pain had, okay, so again, think of our subtypes. For the patients with the IC, the IBS, for the vulvodynia, they had their own unique bacterial profile that was dominated by an enterobacteria. Patients with pelvic floor pain had normal biomes. Patients with bladder wall specific pain had a lot of lactobacillus iners. And so she was able to look at that profile and make it match subtypes. Okay. Let's see. So here's the thing about lactobacillus. Why do we take a probiotic? We take a probiotic because it's supposed to control fungus, and it's supposed to create, it's supposed to restore the urinary biome. But lactobacillus as a whole is considered healthy. But here's the problem with lactobacillus iners. It does not inhibit yeast growth. It does not produce hydrogen peroxide and lactic acid that helps control bad bacteria. Most importantly, it has a toxin that breaks down skin. It breaks down epithelial barriers. So think about the bladder wall, which is an epithelial barrier. So if you have a lot of lactobacillus iners in that, could that compromise the bladder wall? Yeah, definitely. The other thing that she focused on is the role of fungus. Now, many of you know that several years ago, our own National Institutes of Health IC research program, the MAP Research Network, they made a rather remarkable finding. They found that IC patients who were flaring with really significant bladder pain were flaring often because they had fungus in their urine, candida. Patient, and it was a significant finding. When you think UTI, we don't just think about bacteria. We have to think about fungus, and we have to think about a virus, right? So if you are dominant in lactobacillus iners, then you lack the lactobacillus that normally keeps fungus in check, candida in check. Fascinating, 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 fascinating. So the patients who had the highest level of pain were the patients who also had a really significant population of candida in their urine. Now, why are we more prone to candida? Another reason we're going to be more prone to candida is because we've all been on antibiotics for a long period of time. And the antibiotics kill the good bacteria, which killed bacteria. So is the overuse of antibiotics also favoring lactobacillus iners, which does not kill candida like the other good, healthier lactobacillus? So candida is associated with IC. Candida abundance increases with increasing pain overall. So basically what she's saying is that no, they have not found that mysterious bacteria, that mysterious H. pylori, which could be the root cause of IC in everybody. And of course, we know that's not true because so many of you develop symptoms after injuries because you're a different subtype. But these new studies are now suggesting that there is a provable disruption in the good, healthy bacteria in the urinary tract of patients with IC. And that when that dysbiosis occurs, like from taking antibiotics for too long, it begins an inflammatory process that everything basically gets disrupted. So I know I didn't say that as well as she did. I have to listen to everything again. I will be doing lots and lots of articles on this because I want you to understand this as well. But most importantly, you need to see that IC research right now is absolutely fantastic. This is fantastic. And I predict in the next year, we're going to be able to, maybe in the next couple of years, really address the misperception that I see is, how do I want to say this? We know that there's diversity. We know a lot of you, this all began after breaking your tailbone and things like that. But there certainly is a small subset of patients who do have a problem with your biome. You do. And she's given us a big giant clue. And that is this preponderance of this not good Lactobacillus ainer. So I guess my take home here is, if you're taking probiotics, please look at the label and make sure you're not taking Lactobacillus iners, INERS. That's like the early take home, but we need a lot more research that will help us understand a lot more about this whole thing. There's more. What does the MAP Research Network taught us? There's just so much going on with us. So I will have a lot more. I just, guys, I couldn't work for about 3 weeks. I'm still struggling to work a little bit of just trying to get my head in a good place. Jody says, I've been binge watching all of your YouTube streams. You're truly a gift. Oh, thank you, hun. That's so weird. It's so weird. Then people call and I answer the phone and they go, wait, is this Jill? And I'm like, yeah. And they go, wait, you're answering your phone? Yeah, I do. Oh, why? You're a star. And it's like, no, I'm not a star. I'm a support group leader and I do answer my phone. Okay, hold on a sec. Denise says, how's my brother? I talked to my brother who is unvaxxed. She's an unvaxxer. Do not even get me started. Very, very severe COVID. I talked to him yesterday. He's a little bit better, but it's been very hard for him. My COVID was pretty mild and no bladder symptoms at all. I will tell you though, I need to be the case study of how does your IC change during periods of very high stress. I've had 2 wicked pelvic floor flares and they started in the morning. Man, I had vulvodynia. I was peeing every 5 minutes. My muscles were screaming at me. And using a wand, I was able to break that flare within about 20, 30 minutes. Took me a minute to register. Oh, wait, you're having a flare. Oh, wait, it's your pelvic floor. Okay, let's get the wand. If you guys don't know what a wand is, when you do pelvic floor physical therapy, usually they teach you how to do it at home, and you do that with a device that we call a wand, where you can do a little bit of internal massage, and I'm telling you, it works like a charm. Hi, Barbara. Kayleen said, nice having people that care, but nothing will bring them back. You're right. My grandma was with me for my bladder installation 2 weeks before she passed. Fast forward to April's instill, and I needed my ex with me. Yeah. Nothing can ever replace her. But it's true. It's true. I feel them. I know my dad's here. One of the things that my dad used to do during COVID is he would buy all this crazy food, canned food. He bought SpaghettiOs, Chef Boyardee SpaghettiOs, raviolis, corned beef hash, DT Moore beef stew. And literally one of the very first things I did is we donated them to some farm workers. Because I can't eat them because they're too high in salt, and I just don't eat that type of food anyway. And Up at the top, up on my top shelf, there was a 6-pack of canned chicken meat, breast meat. My sister said, "You want that to go?" And I went, "Yeah." And I pulled it. I reached up to pull it down. And I heard my dad say to me, "Don't give up your proteins. You need some protein. Save your proteins." So I know my dad is close. My mom is over with my brother for sure. I have no doubt about that. But she's checking in too, I'm sure. Annie says, bladder porosity caused by antibiotics can leave the bladder sensitive to the acid in urine. Yes. Yeah, it can. Absolutely. When we consider the fact that certain species of bacteria nourish the cells of the bladder wall, and if you kill these important species, the bladder wall no longer has food, and the cells in the bladder wall begin to die. And that's one of the ways that antibiotics can take a terrible toll on the human body. We do not want to kill all the good bacteria too. And the same is true with intestinal porosity. And that's how we learned about this with the early gut biome studies. Thank you, Patty. Patty says she's been sending love. Nan says, thank you for relentless work on IC. You and I have the same type of IC. What would you say is the number one thing that helped you get over the last hurdle to be able to eat citrus? You quit your toxic job, had a year of great physical therapy that helped immensely, but I'm still acid food affected. You know, the physical therapy was huge, but the other really big piece of the puzzle was just taking control of my central nervous system. And just calming everything down. I think once I calmed a lot of the anxiety down and that central sensitization down, things massively improved. And then last but not least, I take Peora, PEA, every day, which also calms nerves down. And that's really helped me too. And it doesn't make sense because I'm older and I'm definitely postmenopausal. And so my skin is definitely thinner, but I can eat a lot more now than I could 10 years ago. And I just think that last piece of the puzzle for me was recognizing my subtype. Yes, I am driven by tight pelvic floor muscles. That's a huge part of my problem. But the other big part of my problem is central sensitization. That the nerves in my body, my entire central nervous system became extremely sensitive because of trauma. And, taking the shame away and taking the blame away of that, it was never my fault. This is trauma driven and physical trauma, breaking my tailbone at the age of 14. So getting my mind in a better place, really, to be quite honest. And I was working with a patient, for example, on Friday, whose anxiety was absolutely out of control. And her, she was kind of having a panic attack and her pain levels were going up and her anxiety was going up, and it was the holiday weekend and she was really worried about finding care. And she called because she wanted support, and which of course I'm always happy to do. And she's like, what do I do? What do I do? And I said, well, the first thing we got to do is take some deep breaths, my dear. We have got to calm everything down here, because what you're not understanding is the more anxious you are, the more tight your pelvic floor muscles are going to get, and the more your pain is going to intensify. We got to break this cycle of anxiety. Let's take some deep breaths and just try to calm the entire central nervous system down. Nobody's saying this is all in your head. Nobody's saying this is mental illness at all. This is just really understanding that some of us have an injured nervous system from trauma. Jody says, I've been, oh yeah. Thank you, Jody. Hi, Barb. Nan says, this candida and antibiotics discussion is mind-blowing. I had a botched surgery at Stanford 20 years ago, in which I ended up getting 80 plus IV bags of antibiotics to keep me alive. I tried every probiotic type and even had a fecal transplant, but nothing has restored my biome. So now I wonder about this for my bladder. Thank you for talking about this. Well, there's going to be a lot more coming up about this. I think kind of the take-home message here, the take-home message is we can't compare the biome of somebody young with somebody older. They're completely different. When we break it out and we just study the biome in the younger patient under the age of 45, that's when we see trends. And the same is true when we study the older patient. That's when we see trends. And the biggest trend that they're seeing in the IC patient population is for patients with pain is that there's a lot more lactobacillus than normal, and it's not a good species of lactobacillus. It's Lactobacillus iners. And so it kind of makes me wonder, hold on a sec. I think we have to be a lot more thoughtful of the probiotics that we're taking, So for example, Bladder Builder has probiotics in it, but there's no Lactobacillus iners. It's Lactobacillus plantarum, rhamnosus, ruder, and yeah. Now let's look at this one, L. flora. Same thing, no Lactobacillus iners. And I have to wonder if Lactobacillus iners might be more common in yogurt. Hold on, let me go get my yogurt. Hold on. Okay. So this is the yogurt I eat, which is a coconut milk yogurt. I try not to do dairy so much. Let's see if okay. Again, no lactobacillus. The live action cultures include rhamnosus, acidophilus, bulgaris, casel, paracel. So there's no Lactobacillus iners in the yogurt either. I wonder where it comes from. Hold on a sec. Let's look it up. Lactobacillus iners. What are the symptoms of Lactobacillus iners? Is Lactobacillus iners protecting or disrupting bacterial vaginosis? Oh, okay. So here, hold on. Lactobacillus. So this is from Massachusetts General Hospital. Okay. Lactobacillus iners, the most commonly found bacterial species in the female genital tract, is associated with an increased risk of bacterial vaginosis and other adverse health outcomes because it has been difficult to study because it's difficult to cultivate in the lab. So they can now selectively block the growth of this led to the discovery of a potential treatment to selectively block the growth of L. iners by promoting the growth of Lactobacillus crispatus. Isn't that interesting? Remember, we are in essence, this giant community of bacteria and fungus and all this other stuff. And so how do the bacteria control each other? They fight it out. They duke it out. And it's the bacteria that control the other bacteria. The good bacteria control the bad bacteria, except the good bacteria control the fungus. And so there's always it's a very dynamic process, and we always want to be supporting the good bacteria rather than the bad bacteria. But oh my God, that just gave me an incredible idea. I'm gonna have to call and talk to somebody. So other than that, I just was physically unable to work. I was at the hospital and doing other stuff. And so I am quite behind. My Spring IC Optimist magazine is quite behind. I do have a very large email newsletter that will be going out tomorrow to our 30,000 plus members. And so if you want our free newsletter, just go on over to the IC Network website and put your email address in the pop-up window. I haven't sent out an e-newsletter since February. So I don't abuse you at all. We have been doing a lot of some email, not a lot, maybe 3 emails about clinical trials this year. We have another email for another clinical trial that's going to go out on the 31st of this month. So it'll go out in a couple of days. And so we've got some good research studies that are coming up too. So, I would appreciate it if you would just send me lots of strength and prayers. It's a strange time. It's just a strange time. So many of you, and if you have words to wisdom to share, I mean, this is the first death we've ever had in my immediate family. It's like being hit by a truck, 2 trucks at the same time. So any wisdom you have, I am open for. Now, you guys are being very nice to me. You got questions I can help you with? Hit me. Give me your challenging questions. I want to hear what's going on with you. I want to hear how your bladder is. I want to hear if you're having a flare. What can I do to help you today? Let me know. That's why I am here. Kayleen says, I got an update. You saw your primary on Tuesday for the hernia. She said I have 1, but she's more worried about the rectal bleeding and that I definitely need a colonoscopy. I'm not going to my Chicago GI because of the long drive or the fact that a B&B is expensive. I went Thursday to get a GI at work. They have a colonoscopy set for August 2nd. August 2nd? What? You're bleeding, for God's sake. This is not a colonoscopy that would be a routine. You have an immediate need for a colonoscopy because you are bleeding. Do they understand that? You are not the typical patient over the age of 50 who's just having a colonoscopy to check things out. They need to figure out why the hell you're rectally bleeding. I think you should appeal that and make sure you get on a cancellation list at a minimum. But that makes no sense because every day matters in a patient who's bleeding. I was working with a lady this week, a couple of days ago, who was anemic. And, getting that colonoscopy done is critical to make sure that we can find that underlying cause of bleeding. And she had a colonoscopy, and she also had the endoscopy to look at her stomach within a week. So that makes no sense that they would push that off for 3 months. That makes no sense at all. I think you need to be the squeaky wheel. I'm bleeding. What if it's cancer? You need to check now. I'm not saying it's cancer, hon, but that's a good way to argue why you need to get in, and you need to be on that cancellation list at a minimum. Girl, I'm telling you, 20 years from now, you're gonna be an absolute case study for, and I just want you to write a book and share your story. Hi, Deborah. How are you, hun? Nan says, what do I take to calm nerves? I take PEA, Peora, which is right here. So this is palmitoyl ethanolamide, which the research with IC has shown remarkable success that 87% of IC patients who took a combination of PEA and resveratrol recorded a significant reduction in their pain by month 3. And by month 6, many were completely pain-free. That research study was presented at the AUA conference in 2019, and this is the game changer. The general consensus among the researchers is that this works by calming nerves down, and it has certainly calmed my nerves down. My skin sensitivity, my skin sensitivity used to be so bad I could barely fall asleep. I felt like I was being poked by needles. It's all gone now. Everything is calm and together and has been life-changing for me. And, I don't like to, listen, guys, I don't like taking anything. I've always felt like I was the queen of side effects. And we had the IC study, and I actually sent the IC study to Natural Approach Nutrition and said, can you make an American version of this? Which they did. That's what this is. And so we had it. And even then I was like, oh man, do I really want to take, I don't like taking anything, but I was struggling so badly to sleep. It's like, all right, I'm going to give it a shot. And I'm so glad I did. I'm so glad that I did. So PEA also happens to be extremely affordable. It's like $28.50 for a month's supply. So it's half the price of the other supplements. So if you're in the central sensitization widespread pain group, I think that this would be very, very interesting to try to see if it would help calm some of those nerves down. Sally says, do you know pelvic floor dysfunction is related to SIBO? Would pelvic physical therapy provide relief? I'm not aware of any direct relationship between the two. And Sally, what the research that was presented at AUA a couple weeks ago showed that patients with pelvic floor dysfunction actually had normal human biomes. They did not show a disrupted biome. So when I look at it in that way, I don't see a connection. But I think we can also argue that if you have SIBO and it's really, really bad, and you're struggling with really severe bowel spasms, your muscles will get tight over time to protect you from that pain. So I think it's more of a guarding reflex as compared to an actual bacterial influence. Would a SIBO bacteria affect the muscles? No. But intense SIBO with intense IBS would certainly cause your pelvic floor muscles to get tight over time. Elena says, you said PEA and resveratrol. What's the latter for? I don't remember off the top of my head what the resveratrol does. I just don't remember, but I can look it up. Let's look it up. I know resveratrol comes from the skin of grapes, I think, grape skin. Oh, wait, I don't want to lose that window. Let me open a new window. Resveratrol. Resveratrol. Resveratrol is a polyphenol, a naturally occurring, highly powerful antioxidant. It is most prominent in the skin of grapes and shines through in natural grape juice and red wine. So it's an antioxidant. Ravonda said, you're looking at getting PEA. Was reading on NIH a PubMed article on PEA that it is an endocannabinoid. Does this mean that PEA is in the cannabinoid family and cannot interact with other meds like CBD? Hun, I don't think so, but I am not an expert in that. I think that is, you're gonna have to do a lot more research on that. I can't answer that question off the top of my head. I just don't know. But you know what? Hold on a sec. Let's see, palmitoyl. I haven't seen any contraindications drug interactions with PEA with anything as far as I'm aware, because I've looked that up before. So Both PEA and CBD target various receptors and can work together to support healthy endocannabinoid signaling. This phenomenon is known as the entourage effect. So taking PEA along with CBD may provide more benefits than taking them separately. That is from a company called Theralogics. Also known as a synergistic clinical benefit. So they do appear to work well together. What's up? Let's see. So what supplements should not be taken with CBD? Because CBD causes sleeplessness or slowed breathing, you don't want to take it with other supplements that also cause sleepiness. An example would be hops, kava, L-tryptophan, melatonin, and valerian. William says, on a side note, I purchased Bladder Builder. We'll start to take it this week. Awesome. You guys, we did get all of our supplements in. They are all in large quantities now. We had to do a huge manufacturing run for the last 6 weeks. And so we now have a good supply of Bladder Builder, Bladder Rest, Cystomend, PEA, along with Cystoprotect, and Allopath and things like that. So we do now have a lot of supplement available. So we'll have enough to get through the summer. Kayleen said, I had pelvic wand vaginal training. I almost peed on the table because it hurt so bad. I went home and found vaginal blood too. Is that normal for the first time? She did stretch all the tissue affected by vulvodynia. Well, Kayleen, I think that your estrogen atrophy is so profound that your skin tore by touching it. That's what happens when estrogen levels drop significantly. I mean, that's the only thing that makes sense as to why using a vaginal wand would cause bleeding. It's not sharp. It's a soft, pliant, I mean, so here's a wand, right? And this is the wand that you use vaginally or rectally for pelvic floor tension. There's nothing on this that would sharp that would cause a wound. So the only thing that makes sense is that your skin is very vulnerable from estrogen atrophy. That's the only thing that makes sense. So we have a different wand on our website that is where is it? It's purple. It's somewhere here. Well, you guys can't see the mess that I have right here. We have a 3-week-old mess that I'm going to have to clean up this week. So my purple one is around here somewhere. But anyway, yeah, that's the only thing that makes sense to me as to why you would have some bleeding. I will have, hopefully in the next month, I will have a lot more of the new information for you to read. It's exciting. It's just a lot of really good stuff out there. All right, hit me up. Give me more questions. You're being very nice to me. But I also realize it's Memorial Day. Kayleen said, she said my labia was lubricated, but she thinks it's from drinking 60 ounces of water a day. Well, yeah, that would do it. That would do it. But ultimately, in the end, we cannot underestimate the role of estrogen. We can't do it. Think about, your bladder is the only organ in the human body designed to hold toxic waste, right? urine is body waste. Urine contains ammonia and urea. So how can the bladder hold ammonia for hours at a time and not get damaged? Well, it's because your bladder's wet on the inside. You have a really thick, robust coating of mucus. And the purpose of that mucus is to serve as a barrier. It prevents ammonia from reaching the cells of your bladder wall, and it prevents bacteria from infecting the cells of your bladder wall. So that nice, thick, mighty mucus, that's what we call it, the mighty mucus, is central to bladder health and vaginal health and urethral health and mouth health. Unfortunately, that mucus is estrogen dependent. So when you're young and have lots of estrogen, you got lots of mucus, you're gold. But if you're on heavy birth control, if you're on Lupron for endometriosis, you've had a total hysterectomy, or if you're perimenopausal, if you're in your 40s, 50s, 60s, your estrogen levels are going to drop to the point that those cells are not going to be able to produce mucus, and you need that mucus for a healthy skin down there. Think about how painful dry mouth is. When you have dry mouth, that hurts. Listen, guys, dry bladder, dry urethra, dry vulva, dry vagina hurts. And therapeutically, when we give that skin estrogen, it immediately starts to produce mucus again. So literally, the most natural thing you can do is to give that skin estrogen. When you give it estrogen, it produces its own natural mucus. So topical estrogen is always going to be the first treatment choice for patients whose symptoms are being driven by dry skin. Ravonda said, I don't take CBD, but was trying to see if PEA would interact with my meds since it is in the cannabinoid family. My IC specialist has no idea, and other doctors really don't know. Ravonda, I've gone through lots of studies, and I haven't found any drug interactions with PEA. What I would encourage you to do is go to the National Library of Medicine. Well, here, hold on. Let's just do. Here, hold on. Palmitoyl ethanolamide. Let's see. Drug interactions. Let's just Google that. Okay. So the first link was from iHerb, not that that's a reliable company. It says PEA is completely safe and non-toxic, and no significant treatment-related adverse events have been noted in clinical trials in humans. There are no known drug interactions with PEA. Now let's go to a little bit more credible website. Let's go to WebMD. Let's see if they have precautions. When applied to the skin, PEA is possibly safe for up to 28 days. You know, the challenge here is that, whoops, we don't have, a lot of long-term data. We need more long-term data. So, but I'm not seeing drug interactions on WebMD. Yeah, I'm just not aware of any drug interactions. Google it. William says, hey, Jill, we spoke on my challenges with insurance covering hyperbaric oxygen therapy. You're still being denied by your insurance. Just trying to gather all the info I can, not giving up the fight. Good. Man, you know, listen, guys. If you don't speak up for your need, if not you, who? If not you, who? We have to speak up and advocate for ourselves every single time. If you follow Dr. Glaucoma Flecken, he is a fabulous ophthalmologist up in Oregon who does a lot of hilarious videos. And he is just showing really the absolute evil in some health insurance companies. that they're denying so much just to save money rather than to actually address the needs of that patient. And so we have to be the squeaky wheel here. Ravonda says, how else would I research PEA and medication interactions? On the National Library of Medicine website, PubMed. Pub short for publication, med short for medication. So let me give you the link, pubmed.gov. And yeah. So you're just going to have to read as many studies as you can. Chloe said, would an active UTI cause tight pelvic floor muscles? Hell yeah, definitely. If you got an active painful UTI, your muscles will get tight to protect you from that pain. That's called the guarding reflex. So yes, that active UTI is sometimes the original trigger for this. And even though the UTI has been killed, whatever that pathogen was, sometimes the tight pelvic floor muscles remain. And so we've got to make sure that we address the tight pelvic floor muscles too, because there is a terrible long-term toll to tight pelvic floor muscles with the bladder and the vulva and the rectum, etc. Tight pelvic floor muscles are also known for causing constipation. So when you go to urinate, if you can't start your stream right away, if you hesitate 5, 10, 15, 20 seconds before you can relax enough to release urine, that means you have tight pelvic floor muscles. So we got to do something about those tight pelvic floor muscles. Hi, Donna. Hey, girl. Nice to see you. I'm here. I'm about 70% of normal right now. Kayleen says, thank God I see a urogynecologist on Tuesday. He's going to help with the, okay, because I can't from your PTSD. I want to hear his opinion on your rectal bleeding. Good. Man, the more eyes and ears looking at your body and studying your body, the better. It is a complex and tricky situation. That's for sure. Flo says, I'm glad you're feeling better. Yeah. The COVID is just weird, you know? I mean, it's just like, I didn't have any severe symptoms at all, other than maybe 2 coughing attacks. But it's just like there's this legacy of like congestion, like right here. Boria, you got COVID too? So like there's a really, really big, very, very good IC conference in New York in July. The schedule is amazing. It is like the conference of conferences for people, you know, who do the work that I do and the doctors. And I was like, I can't go and bring COVID home to my parents. Oh, Boria has a bad cough. Oh, I'm sorry to hear that, Boria. Well, now that my parents have passed, I could technically go, I don't want to get COVID again. Man, and the thing about COVID is the long-term toll on brain health and dementia. So I'm like torn. I'd really love to go to this conference in New York, but am I willing to risk my own long-term health? I don't know. Cartsy said, when did I get COVID? I got it in the hospital sitting with my my parents. My dad had a heart attack and he lasted 3 days, and I did hours and hours and hours at the hospital with him. And then my mom collapsed. And so the hospital got them together for my dad's last day. And, you know, it was so strange because my mom was doing so well. I was like looking at her going, God, she's doing really good. She's doing really good. And then literally on the third day, she started having grand mal seizures. She never had a seizure in her life. And I just think that that was her spirit saying, I can't be here without Dad. I have to be with the love of my life. So anyway, we get her to the hospital after the seizures, and they get them in the same room. And so they were together. They didn't know they were with each other, but they were in the same room. And we were there for 15 hours straight. And my mom, I went back down the next morning and I had to tell my mom that he had passed. Within an hour, she started having seizures again. And so that was just her spirit, I just think, saying she needed to be with her husband. I just wish, I came home. I came home that day and I walked into their bedroom, which is right over here. And I just said, all right, guys, seriously, I know and understand that you have to be together. You were together for 75 years. I understand that, but for God's sake, give a girl a little warning. just out of the blue, one day he's good and the next day he's dying. I thought I would have my dad for another couple years. He was so strong. I think that's the part that's the hardest is, like you guys saw him a month ago. Walk in here asking for food. I think it's the shock of it that's the hardest. Christine said, I had rectal bleeding on and off for almost a year. My colorectal surgeon found a 2-centimeter polyp in my rectum. I had a colonoscopy and the removal of the polyp in March. He found no polyps in my colon and your rectal polyp was benign. Awesome, Christine. That's great news. That's absolutely great news. I'm due for another colonoscopy. I had one when I turned 50, but I just did the blood, where they test for blood in your bowel movements, and it came back negative. So I'm not going to sign up quite yet for another colonoscopy. But anytime you have blood, you want somebody to look because those polyps, and this was a problem that my mother had. If you struggle with long-term constipation and or if you are a chronic strainer, you're straining to have bowel movements, that there are issues with that. There is a toll that is taken with straining. And so you can develop a diverticulum, you can develop a prolapse from long-term straining. And so straining is never good to have a bowel movement or to empty your bladder. That is, in the long run, going to do potentially serious damage that will require surgical repair. So don't strain. If you have tight pelvic floor muscles, you've got to go to physical therapy. It works, and it works beautifully. Donna said, ever since I got back from Germany in February, my IC flares have been off the chart. You just can't get a handle on it. My doctor's appointment in June 8th, my vaginal area is on fire. Donna, I got to tell you, I was saying I would like to be a case study, and you and I together could be that case study of severe stress and how does severe stress affect our pain. So what happened with me is I have had 2 absolutely wicked pelvic floor flares. Wicked. And I had vaginal burning. I had my skin felt like it was on fire. I had urethral pain, and I was peeing literally every 5 minutes. And it just came. It's just so suddenly. 1 minute you're fine, and the next minute, bam, the muscles lock down tight. And they were pelvic floor flares. And I stopped both of them in their tracks I just dropped trow and did a little internal work, and then I went back an hour later, did a little bit more internal work, and I was able to stop all the burning with this, you know. So if I were to guess, I think two things are going on for you and me. I think that our muscles are on a hair trigger from stress. And we also have to understand that stress makes nerves more sensitive. And so I think our nerves are going to be a bit more sensitive. But I use PEA, so I think that that's really keeping my nerves fairly under control. Kartsy said, I had to go completely whole food plant-based to fix my bowel movements after cancer radiation surgery. It works wonders. I've never pooped so well in my life. Yay! Yeah, you know, I mean, today's modern diet is so bad. And it's so important that we get back to eating good, healthy veggies and proteins and stuff like that. So I have been eating, so I'm doing fine in that department. My breakfast is normally Ezekiel bread with almond butter on it, or a scrambled egg, wait a second. What's the hot one that I do? Oh, or gluten-free pancakes. I will make gluten-free pancakes. I don't use syrup. I rarely use syrup. I rarely use anything sweet. And for dinner, I'm one of those people where, because of my IC and my IBS years ago, food, it was never my friend. You know, a lot of people love food and they love going out to eat. But when you have severe IBS when you're young, food is not your friend. And so we tend to stick with the foods we know we feel good. Like literally just give me vegetables, tofu and rice, or vegetables, chicken and rice, and I can eat that every day and I never get tired of it. So for dinner, what have I had? That's what I had this week twice. I've gotten split pea soup a couple of times. And I had a chicken salad sandwich yesterday. Michelle says, I'm thinking you'll have good immunity in July. I would love to see you be able to go to this conference now. Thank you, Michelle. You know, I will be very honest in saying that my travel partner was that woman right there. Every major trip I've made in the last 30 years, she's been at my side, or my sister has been at my side. I always felt very comfortable traveling alone, because, I mean, you're standing in the security line, but you have to pee, right? You have to pee. So I got to go pee. Now I'm going to end up at the back of the security line again, right? So I have a little travel phobia. Can I do it? Yeah, with medication. So I was last night trying to figure out if I could fly out of my local airport, Santa Rosa Airport, Charles Schultz Airport. And because we have Alaska Airlines, but United left my airport. So if we had United, I could fly from Santa Rosa to Denver and Denver to New York. Break it up in 2 trips. I've done that before. So, I mean, the other thing is, I listen, every medical conference that has happened in the last 2 years, a massive number of doctors have gotten COVID, including AUA a month ago. And then, you know, you follow their Twitter feeds. Yeah, who else got COVID at the conference, right? And it's just like, so you're willingly walking into a room with people from around the world who have all flown in, all bringing their own potential strains of COVID. And it's like, God, I just, do I want to do that? If we didn't have COVID, I'd do it in a heartbeat. I would do it in a heartbeat. But I don't have enough money saved up to handle not being able to work. And I don't want to risk getting very ill like my brother. And I'm fully vaxxed. You know, I am fully vaxxed. Donna says, I found a probiotic called Seed. The capsules are protected with an outer coating, which allows the probiotic to work better. But Donna, you got to look at the probiotic and make sure it does not contain lactobacillus iners. Because I think you came in late, we were talking about the new research. And what they're finding with the microbiome studies is that patients with patients who are struggling with more pain, who are under the age of 45. Well, I got to take this back. So what the microbiome studies show is that the IC biome is not that different from the normal biome, except we have fewer species and we have a predominance of lactobacillus, a quote unquote healthy lactobacillus. The problem is when you look at the different variants of lactobacillus, some of us have high levels of a bad lactobacillus called lactobacillus iners. Lactobacillus iners, why do we take lactobacillus? To control candida. Unfortunately, lactobacillus iners does not kill candida, and it produces a substance which breaks down skin. So this is potentially another mechanism of action that would help us understand why bladder walls get injured. In some of us, not all of us, but some of us. Chloe says, I hope they have a live stream component. Yeah, they're supposed to. They say Robert Muldoon is sharing the event. It's the International Society for the Study of IC and Bladder Pain Syndrome. So it's a medical conference for professionals, just not for patients. But it's a to die for conference. It's going to be like the best conference in a century. Let me here, hold on a sec. Let me give you an idea of, okay. Okay. So this is the program. It's a phenomenal program. So on the first day, July 6th, IC guidelines around the world, will we ever agree? It's important that we do agree. You know, we don't want one country treating IC one way, and we got to have consistency, especially with the internet. Should we classify Hunner's as a rare disease? For God's sake, yes. Hunner's lesions is a rare disease. It is its own unique disease. Is it time for a name change? Should we be calling, I mean, Europe is no longer going to use the term interstitial cystitis anywhere. They're going to start using primary bladder pain syndrome. So the term interstitial cystitis is going to be phased out entirely through most of the world, including hopefully in the US. It needs to be phased out, which means we got to come up with a new name for the IC network. Widespread and local pathophysiology. What's the difference between local symptoms versus widespread central nervous system? Cellular events within Hunner's lesions. What else happening inside Hunner's lesions? There's the next day, diagnostic dilemmas. Is it IC, chronic pelvic pain, or both? What are the other related conditions? Office cystoscopy versus bladder hydrodistension, pros and cons. Patients with a positive next generation report. What should a clinician do if you're doing next generation DNA urine testing? A 3-step approach for the proper diagnosis of bladder-centric IC using artificial intelligence. Endometriosis and bladder pain syndrome, are they evil twins or distant cousins? I thought it was IC. It turned out to be something else. If only I had. That's a course. Phenotypes, cognitive behavioral therapy. Yes, so important. Diet and IC. Robert Muldoon's teaching that class. Eye changes associated with the use of Elmeron. Compounded topical therapies for pelvic pain. Such a good class being taught by Christine Whitmore. Immunomodulation. Third day, treatment strategies, future treatments, current clinical trials, treatments for high tone pelvic floor, nerve blocks for pelvic pain, Botox for the IC patient. What are the best practice? Use of neuromodulation, surgical approaches. Like, oh my God, Can this get any better? It is such a freaking good conference if you're a nerd like me. Oh man, I won't have my new teeth yet. It's so I'm going to have my implant surgery on June 8th. Yeah, I think I told you that I had my teeth cleaned in November and they destroyed two teeth, two roots. So I've had missing teeth over here. Anyway, the conference just looks absolutely fantastic. Sue says she loved the photo of my photo. Yeah, that's my favorite. This is my favorite picture of them. My mom always wanted pictures of her holding the flowers that she got from my brother, because my brother didn't come over. He would send flowers. Oh, thank you, Donna. Donna says, I'll let you know how the appointment. Yeah, I really would like to hear about it. Would really like to hear about it. Let me go over, since we're here, let me go over a couple of other things that were taught in the IC class. Let me look at my notes. So, you should remember that we have national guidelines. The national guidelines are produced by the American Urology Association. They were first written in 2011. They were updated in 2014. And they were updated last year in 2022. And the update last year was a really significant update because they now admit, understand that they are distinct patient groups. So again, the old, here's the diet, here's Elmeron, see you in 6 months is gone. They are now focusing on trying to find what your unique group is so we can give you the right treatment for your unique presentation of symptoms. Now, AUA is very slow, so they don't have the 5 subtypes or the 9 subtypes. They're willing to admit that there are 3 subtypes. And their 3 subtypes are Hunner's lesions, pelvic floor, and widespread pain. Did I get that right? Okay. Yeah, I got that right. So, so what are the changes? Probably aside from them saying we've got groups, they no longer have that 6-step treatment approach. Remember, that's what we had for many years from 2014. They wanted every patient to start with step 1 treatments, which were basically diet modification, muscle relaxation, stress management, basic education, etc. And then if those didn't work, then you would go to step 2 treatments, which were oral meds, physical therapy, bladder instills. Then you would go to step 3, which is physical therapy. Then you go to step 4, which is neuromodulation, Botox. Then you go to step 5, which is cyclosporin. And so I think the goal with that was to give you a very predictable pathway. Well, they've decided that that's just not flexible enough now that we have groups. And so we don't want to put you through a 6-step treatment protocol. We want, if you find Hunner's lesions, for God's sake, treat the lesion. Don't wait till step 3. If you've got tight pelvic floor muscles, go. I mean, there's only 2 recommendations in the new guidelines. Strong recommendations for treatment. Number 1, if a patient has tight pelvic floor muscles, you are to send that patient to physical therapy immediately. And if that patient has Hunner's lesions, you are to treat the lesion immediately. And if that patient is over the age of 50 with severe symptoms and more severe blood in their urine, you should be looking for Hunner's lesions and treat them immediately. So our guidelines are really focused on acknowledging your pain, addressing your pain, and treating your pain quickly. They don't want you to suffer. What's a number 1 cause of long-term intense chronic pain in the IC patient population? A Hunner's lesion, which has not been treated. And I just, again, last week, working with a patient, told she had Hunner's lesions. They were never treated. For God's sake, what the hell? You find them, you're in there looking at them, treat them at the same time. don't force that patient to have another hydrodistension to get it treated. We want to treat the lesions when we find them. So if you're scheduled to have a hydrodistension, one of the most important questions you are going to ask that doctor is, well, there's two important questions. If you find a lesion, how do you propose to treat it? And if the doctor says, I'm not going to treat it, you're going to say, why? And if the doctor says, I don't have the equipment to treat it, you're going to go, oh, well, who has the equipment? If that doctor says that they are not going to treat Hunner's lesions, I personally would not have a hydrodistension with that doctor. If I have visible, I mean, guys, seriously, if you have visible blood in your urine, and it's amazing, again, last week, I was working with one patient, her toilet was filled with blood. Like, if you have visible blood in your urine, we want somebody to look in your freaking bladder to figure out what the hell's bleeding. And that's a cystoscopy or a hydrodistension with cystoscopy. And one of the most common causes of blood in the urine of an IC patient is an untreated Hunner's lesion. So we want them to look. We want them to cauterize the lesion or inject the lesion with a steroid to stop you from bleeding. Right? I mean, that makes sense, right? So it always breaks my heart when I work with a patient who had lesions and they were never treated because they've suffered needlessly. And as I said in the class, 85 to 90% of patients who have their lesions treated completely respond beautifully. That for many of them, their pain goes away completely once we cauterize and treat the lesion. So how do they treat the lesion? There's three ways to treat lesions. They can cauterize it. We call that fulguration or laser therapy. They use heat to seal the wound. Number two, they can inject the wound with triamcinolone, a steroid, to try to reduce the inflammation. Or number three, hyperbaric oxygen therapy now has some good research behind it showing that that can be quite successful in treating lesions, as William over here on YouTube is trying to get his insurance to approve. William says, hey, I'm leaving for Italy next week. Go to the conference. Sure, I'm stressed, but you have to live your life. I work in conventions. We do large groups from around the world. No issues. It's time to move on. Thank you, William. Thank you. Cartsy says, maybe optimize your vitamin D levels and just go to the conference if you want to. I take 3,000 IUs of vitamin D3 a day. I take vitamin D several times a week myself. If anybody's watching who lives in New York, call me. I'm not a fan. I mean, I've been to New York before. I got bed bugs at a hotel in New York when I was a kid. I've been to New York twice. This is I think it's in the Bronx. Yeah. Chloe said, you mentioned something about Lactobacillus crispatus. Can you repeat that? Lactobacillus crispatus apparently kills Lactobacillus sinus. And so for patients with an overgrowth of Lactobacillus sinus, they give them the crispatus and it reduces the evil Lactobacillus. Ravonda says, will we be able to watch the conference virtually? Well, they were trying to set it up now. Can patients watch the conference? It's not a patient conference. It's a medical professional conference. That's my job, to interpret the result, interpret the information from the conference for you. Cartsy said, bed bugs freak me out. Yes, I have issues with motel safety too. Yeah. Well, I was looking at hotels too. I'm thinking about it. That would be, they always say, do the thing you fear. And yeah, we'll see. We'll see. I am extremely stressed out right now. I don't know if I'm strong enough to do something like that right now. You know, I mean, I look at my face and go, oh my God, what happened? You don't see it. I see it. I feel like I've aged 20 years in 3 weeks. Sue says, coffee free, pain free for 6 weeks now. No pain until I drank too much Ticino. Interesting. So Ticino is an herbal tea, an herbal coffee. And I actually don't like Ticino. I found it to be way too bitter. And so I do calf-free Roma I'm sorry, Dandy Blend very successfully. Dandy Blend. Dandy Blend is in my opinion the best herbal coffee. I make frappuccinos with it, lattes with it. You put pumpkin spice in it, cinnamon in it, vanilla in it, anything. Oh, hey, let me go put my yogurt back in the fridge. I'll be right back. Hey, water break. Everybody, if you need to go to the bathroom, have some water, go do it right now. We'll be back in shortly. All right, I have returned. Yeah, Ticino does have a lot of flavors. I don't know, it's just too bitter. I just think it's too bitter. It's made of the same stuff, pretty much, except Dandy Blend has dandelion root in it, which is um, um, which is sweeter and it balances the bitterness. That's why Dandy Blend is so good. Thank you, Ravonda. Lots of makeup. Lots of makeup. Donna says, I crawled to Germany. I know, girl. I know, but you got there. Cartsy said, you've been through a lot. Follow your gut. Yeah, I'm really fundamentally empty right now. Donna says, I had my husband and he was still concerned you had to have a wheelchair at the airport going and coming back, but you did it. And you don't regret it. I know you don't regret it because you were there. You were there for your son. And that's a very powerful and strong motivation, right? All right. Any more questions? Come on, guys. You're being very easy on me. You're being very easy on me. Oh wait. So yeah, see, that tells you how distracted I am. Okay, see, my hair is being weird, and I'm being weird with my hair right now. So let me go. Let me go through some of my notes from the conference. Okay. Okay. So getting back to the conference, the AUA class on IC. Um, So we know in the widespread pain category that many patients have fibro, Sjogren's, migraine, tension headaches, vulvodynia, endopelvic floor. And interestingly, a fibromyalgia researcher created a bladder symptom scale for patients with fibromyalgia and bladder issues. In 2023, we still can't identify a cause in everybody. There can be a bladder insult, bladder trauma, infection, neurogenic inflammation, autoimmune disorders, regional or widespread pain syndromes causing this. Some patients can have mast cell activation and histamine release. But they think that a progressive injury appears to occur in patients without Hunner's lesions that lead to centralized pain with widespread or regional pain syndromes. That Hunner's lesions are their own unique group. And so that's really an important concept to help us understand why nerves get involved and why other conditions get involved. A progressive injury. So our treatments are no longer in step 1 to step 6. The 2 recommendations in the new guidelines: refer to pelvic floor physical therapy, treat Hunner's lesions quickly. All the other therapies are options. Patients who are at high risk. So one of the things that that AUA thinks is very important, and I think is very important, is how do you know if you're getting better? How will you be able to tell if the treatment you're using is successful? Well, I mean, because this is important, because a lot of patients stop treatments because they go, I'm not any better. But what if the improvement is very subtle and slow? We'd hate for you to stop a treatment that's actually working for you just slowly, right? And so AUA recommends that you do a baseline voiding diary for 3 days before you start your treatments, because we need to have a start value so that we can figure out if things are getting better or not. So let's just say you on average are peeing 24 times a day, but then you start physical therapy and now you're peeing 15 times a day. Is that an improvement? Hell yeah, that's an improvement. But you might not have been aware of that if you weren't tracking it. And so having some original statistics is important. And then, just doing random 3-day diaries so that you can, especially before a doctor's appointment, so that you can go, okay, I was peeing 20 times before, now I'm peeing 15 times. We're moving in the right direction. I was getting up 6 times a night before, now I'm getting up 2 times a night. Now we're going in the right direction. They also really want you, the patient, to be central in the decision making for treatments. They want the doctor to talk about your treatment options, explore the pros and cons, and get you involved in deciding what treatment to do. Because basically, the oral medications are all about controlling symptoms. They're not going to fix an underlying problem, but they're going to potentially make you feel better, right? So Elavil, an antidepressant, can help calm nerves down. Physical therapy, which is you don't cure an injury, you heal an injury. Physical therapy is stunningly successful. How about the antihistamine hydroxyzine? Well, now we know hydroxyzine in research studies is barely above placebo unless you have a history of allergies. If you have a history of allergies, hydroxyzine can be very helpful. Missy says, I'm just tuning in. I'm so sorry for your loss. Oh, thank you, honey. They are together. There's no doubt about that. Thank you very, very much. So be willing to do a little bit of work and do a voiding diary. We have a free downloadable voiding diary over on the IC Network website in our free downloads area. Hold on. Let me open the slides here. Hold on a sec. Let's see here. Nope, it's not that one. Nope, it's not that one. The other really big change they made in the guidelines is that they dramatically expanded discussion about surgery. Now listen, it's completely normal to ask your doctor, can you just take my freaking bladder out? I don't want it anymore. Please take it out. I did that. I actually asked my doctor in 1993 to remove my bladder. I was sick of the pain. And thankfully, Dr. Klein said, no, Jill, I'm not going to take your bladder out because you haven't done any treatments yet. Well, thank God. Because surgery is only done for patients who have not responded to treatments or patients whose bladder has become very fibrotic and small. In other words, it doesn't expand to hold urine anymore. It's like the size of a walnut. Or in patients with Hunner's lesions and the lesions are just not responding to therapy. They make a very strong point that the surgeon should be very experienced and be dedicated to your long-term care. Surgery, whether it's a bladder augmentation where they take a piece of intestine and attach it to your bladder to increase your bladder capacity, or if it's a cystectomy, removing your bladder, which is rarely done, but there are some occasions where it has to be done. This is not an easy surgery. This is a 1-year recovery. You're going to need a hell of a lot of help in that recovery. And that's not only help at home, but that's really having a good doctor who's going to monitor your progress. We have a bladder removal support forum over on the IC Network website that you can go check. Obviously, our forum is free, and there's a lot of good information over there. If you have widespread pain, if you have pelvic floor dysfunction, they do not recommend bladder surgery because that widespread pain is not coming from your bladder. It's coming from your central nervous system. And worse, surgery would just be another trauma to your central nervous system. And if your pain is coming from tight pelvic floor muscles, why would you want to remove your bladder? That makes no sense. We need to fix the muscles and restore blood supply, right? So their expansion of surgical criteria is very, very good. They're also very assertive about pain care. They want your pain assessed at every doctor's appointment. They want your pain treated compassionately. They are not against the use of opiate medication at all. They support the use of needed opiate medication. And so they make a case for that in the guidelines. Of course, getting a doctor to go there is a whole nother story. Thank you, Sherry. But understand that they understand that this pain can be life-changing, and we want to get rid of it. We want you to have a normal, healthy life, right? And the good news is now that we do subtyping and phenotyping, many patients are getting dramatically better. And if you're not responding to bladder therapies, if you've been doing bladder treatments for 20, 30 years and you're still flaring like mad, maybe the bladder treatments aren't working because maybe your fundamental problem is not your bladder in your first place. And we have to rule out other obvious things like, could you have a fibroid tumor pushing on your bladder? Could you have endometriosis on your bladder? Do you have scar tissue on your bladder? Who was I working with? I was working with another patient on Friday who has a visible lump by her belly button. Like it's visible. You can push it in. It's a hernia. It's an inguinal hernia. And, she wanted to know if that could be playing a role in her symptoms. And the answer was, yeah, it certainly could. It certainly could be. So we want to look for other things that can also be playing a role in these symptoms. And you just have to, as a patient, you just can't keep going, it's UTI, it's UTI, it's my bladder all the time. The symptom of frequency urgency is most often driven by tight pelvic floor muscles, not your bladder wall. And, I got to be honest, when I went and peed, I could feel that my muscles were tight. I could feel them tightening down again. I could not start my urine stream right away, and my urine flow was medium. And that tells me tonight I've got to do some pelvic floor work to keep my muscles. As long as I keep my muscles healthy, I'm doing good. If I don't keep my muscles healthy, I'm going to struggle. Let's see what else. Here we go. So good. God, there's just so much information here. I'm sorry I can't be as cohesive as I'd like to be, but I just haven't had the time to go through everything. They go through all of the research. The MAP research is the most comprehensive study of IC and chronic pelvic pain ever performed. They believe that Hunner's lesion patients is distinct. Hunner's lesion patients were not studied as part of the MAP research network. Oh, so much. Unfortunately, I can't turn on my screen sharing and share this with you. We're not supposed to do that. Let's see if there's anything else in here. They talk about how to do an exam, a pelvic floor exam. It's very cool. So they tell urologists exactly how to do it correctly. They talk about the brain imaging. We now know that patients who have widespread pain are stuck in a constant state of fight or flight in that central nervous system. That's huge. So we know the brain actually adapts and changes under periods of high stress. That can lead to more pain. That's important. Here's the biome studies. Pretty much what we've already done. Anyway, give me another couple weeks so I can absorb it all. Too many big changes. Hi, Sue. And another Sue says, I've had an A&P repair and a year later Marshall Marchetti surgery. Can it have anything to do with that now? It could. It could. Let me look at something real quick. Hold on. Anytime they're messing with the pelvic floor, Sue, it could be a challenge. And the challenge with having surgery for incontinence is that it is really quite difficult for that surgeon to, whether they're using mesh or they're using your own tissue, as they're trying to lift everything back up into position, they have to find the right muscle tension. And they do that with their finger. That's why you want somebody really experienced who's done a lot of surgery. Good, healthy muscle feels like a raw chicken breast. A tight muscle feels like a painful beef jerky. So it's not unusual for a surgeon to go too tight or too loose. And there's a very delicate balance trying to find the right muscle tone to help these patients who are having pelvic floor surgery. And so if your surgery left you too tight, that could cause a lot of pain. And Sue says you were never incontinent. Why? Okay. Did you have a childbirth injury? What triggered the surgery then? What triggered the surgery? And Sue is asking about wands. Do pelvic floor wands that you have a vibration setting if you have a tight pelvic floor? A checkpoint would be a good idea if they can be used on or off. I don't have any vibrating wands in the IC Network store right now. I want to get them. We just haven't gotten there yet. I don't know, the early data using with a wand that vibrates appears to be quite good for helping pelvic floor muscles. I just want to make sure we know how to do it correctly, how to use it correctly. I would hate to put a vibrating wand exactly on top of a sensitive nerve, I would hate to do that. It would be awful. You can't, so you had a prolapse where the bladder protrudes into the vagina, right? So you had a prolapse. And so that's when they would do these surgeries to repair the prolapse. And it's just very tricky. It's very, very tricky. Yeah. Yeah. Do we know why you had the prolapse? Was it that you had children and your muscles got injured? Or do you think it was due to aging and your muscles just getting weaker with aging? What do you think triggered that? Sue says, I was looking online and noticed they made them, but I didn't know if it was a bad thing because you don't sell them. No, I just haven't gotten there yet. Ravonda says, please take your time to recover from COVID, rest and relax. Yeah, I that's really the priority. I'm not healthy right now. I am not healthy emotionally, just with grief, and the COVID is just sitting right here. It's just stuck right here. Sue said no one ever said there was any other option. I mean, and that's where getting second opinions are important. If like as an example, to give you an example, I had when my dentist retired, I went to a new dentist who broke my mouth guard in front of me and said I needed $5,000 Invisalign. And I went to another dentist who went, no, that's ridiculous. He was just trying to get, just trying to get money from you. So that prolapse can happen for a lot of different reasons. It can happen because of injury. If you were a gymnast, an ice skater, if you fell multiple times on your pelvis, if you had a broken tailbone, it's not necessarily age related as much as it's trauma related. The age matters because muscles weaken over time as estrogen levels drop. But really, normally, we're going to look at trauma of the pelvic floor as an underlying cause, Definitely. I'm sorry you had to go through that. And it would be fascinating to have a pelvic floor assessment now and see how your muscle tone is now. Because if your muscles are tight and you can't relax enough to release urine, then that's going to be contributing to your IC for sure. So physical therapy might be an option, but if the sling is too tight, the surgery is too tight, they might even need to go in and loosen it a little bit. Oh, the joys of getting older. Too many joys of getting older. All right, guys. Well, I don't know about you, but I'm kind of fading here. I'm kind of fading. At least I got on and washed my hair. No, I mean it's just been I'm just had a rough couple of weeks. So I think I'm going to call it here. And next week I will have a lot more information for you and with all the new stuff. I'm just kind of, I think the worst of the grief is behind me, but it's just, you know, I'm feeling pretty empty on the inside right now. So Sue says, "Do you take care of you? Don't get overstimulated." I don't feel overstimulated. I need to get outside and I need to go be in nature for a while and just calm everything down. It's all about calming things down. So I will see you guys next week. All right. Thank you for coming. If you like these meetings, come on over to the IC Network website, become a member, get our magazine. And remember, we have lots of really cool stuff in the IC Network shop, like low acid coffee, low acid jams, all the supplements, all that sort of stuff. All right. All right, you guys. All right, YouTube. I will see you guys later. Facebook is done. I'm going to go plant some plants that I bought at the nursery.